So the main goals of screening athletes is to avert a cardiac complication of an undetected heart complaint that might put that individual at risk, particularly during sports and exercise. Inherited conditions or other conditions that young people can have and yet still perform at high level are not as rare as we believe or as the population might consider. It is possible to harbour a significant heart condition and yet still be able to perform sports to very high and even Olympic level or professional football level. These individuals day to day may have a full exercise capacity, in fact, supernormal exercise capacity, but harbour a condition that under certain circumstances may put them at risk. The screening is there to detect the kind of condition that might put these athletes at risk. So there are essentially three different things that can go wrong with a heart. This is the blood supply, i.e. the blood vessels to the heart muscle itself, or the electrical signaling within the heart muscle. With regard to the blood supply, the furring up of arteries with cholesterol is usually a midlife onwards problem. So for young athletes, this is not so much of an issue. For a veteran athlete, somebody over the age of 40, we would want to consider that. And those conditions can be picked up in part by a questionnaire to look at someone's risk for coronary artery disease, but also by questions of symptoms. In a younger individual, the risk of a blood supply issue is really about the anatomy of their arteries. And this can actually be picked up using an ultrasound of the heart. The other problem that can happen is a heart muscle condition, generally something called a cardiomyopathy. And the way that we screen for that is with a combination of a questionnaire, in particular asking about any family history, because many of these heart muscle conditions can be genetic and run through a family, presenting either with symptoms or heart failure, or tragically sometimes with a sudden death. We then also use the ECG to look for the electrical health, which can sometimes reflect the heart muscle condition. And then lastly, we often include an ultrasound called an echo scan, which will look at the function of the heart muscle, look at the thickness of the heart muscle. The third problem that can cause issues in athletes is an electrical problem that day to day does not cause a rhythm issue, but can under certain circumstances cause a very fast heart rhythm leading to a collapse or even a sudden death. The ECG is done routinely. It takes a few minutes and it can detect concealed problems such as long QT syndrome, Brugada syndrome, and pre-excitation or Wolff-Parkinson-White. So one of the most important tools that we have to detect heart muscle or electrical problems of the heart is the ECG. It is a test that's been around for at least 100 years and is done in exactly the same way it was done 100 years ago, and yet is incredibly helpful to detect electrical problems and even some heart muscle conditions. The ECG is done by putting stickers across the chest and one on each limb, and by that we can look at the rhythm of the heart, but also the electrical signal as it passes through the heart muscle to detect conditions such as long QT syndrome, where the electrical activity is affected by how excitable the heart muscle cells are. Brugada syndrome, which again is an electrical problem that can be apparent and detected on an ECG, but is sometimes concealed. And there can be changes related to underlying problems with the structure and function of the heart. Just by looking at the ECG, we can see some of these conditions. So the symptoms that are most important are ones of chest pain, and this can be experienced as a tightness or restriction or discomfort across the chest, sometimes going up the throat, sometimes down the left arm, brought on by exertion. Fleeting symptoms of stabbing type pains that last seconds only and occur at any time are highly unlikely to be due to a heart problem. But symptoms that come on, particularly with exercise across the chest, should always be investigated. Another symptom is of undue breathlessness. Now, everyone gets breathless when they exercise. But if someone starts to notice that their breathing is really becoming troubled when they're exercising, when normally it hasn't been an issue, or they are struggling more than their peers within the same sports team, then that is something that may need to be flagged up. It could reflect a heart problem. It may even reflect asthma or exercise-induced asthma, but it should be looked at. Palpitations are also sometimes a red flag for a heart problem. Palpitations are an awareness of your heartbeat, often faster than normal, sometimes heavier than normal, sometimes experienced as extra or skip beats. Occasional extra beats are super common and should not always worry. Sometimes it's worth getting them checked out, especially if there are other factors. But symptoms of a sudden onset of rapid heartbeats, particularly during exercise, but actually at any time, that last several minutes or longer, particularly if they're brought on with symptoms of chest pains or dizziness, should always be investigated. Symptoms of dizziness are also important to investigate. Many people, particularly young people, can feel dizzy when they stand quickly. Often that's really easily addressed by good hydration and drinking lots of water, particularly front-loading that water at the beginning of the day. But if individuals are getting dizzy during exercise, that may need a further assessment. A faint or a collapse is a big red flag. And if that faint or collapse with loss of consciousness happens during exercise, that must always be investigated. Fainting or collapse with loss of consciousness immediately after exercise may reflect just a simple faint. But again, I would always go to a healthcare professional to get assessed, even if we think it is just a simple faint. Around half of individuals who suffer a cardiac arrest or a sudden death have had a warning faint or collapse before they suffer that tragedy. In terms of family history, it is really important to flag up any family history in a first-degree relative. That's a parent, a sibling, or a child, where there has been a heart issue before the age of 60, or a tragedy of a sudden cardiac death before the age of 60. This sudden cardiac death could present in different ways. It can, for instance, present as a clot death or a stillbirth that may reflect an inherited heart condition, often not, but sometimes it can. For instance, the need for investigation where there is epilepsy in the family with collapse, where there are young pacemakers within the family before the age of 60. Very rarely, an unexplained drowning or a car accident can reflect an unexpected cardiac arrest. And again, this should be mentioned if there are other symptoms within that individual or a family history of concern. So, in summary, a family history should be flagged up if a close relative has died suddenly or had a clear heart issue before the age of 60. For screening, there is often a plus and a minus, as there is for many things. The advantages of screening, obviously, are detecting a concealed or unknown heart condition that might lead to treatment or measures to avoid a complication. The disadvantage is that we can have so-called false positives. We can pick up things that may never cause that problem, a problem to that individual, but may cause alarm, or we may falsely overdiagnose. Now, in the past, there was a bit of an issue in falsely diagnosing athletes because of their ECG. And we now know that if an individual undertakes a certain amount of exercise, generally at least 5 or 6 hours of aerobic exercise a week, their hearts can adapt to that exercise, and changes on their ECG and sometimes even on their ultrasound can be seen. This is so-called athletic adaptation. We are now a great deal more accurate about distinguishing those adaptations seen on an ECG or echo from the changes that we see in disease. So the chances of a false positive are now getting smaller and smaller. So the screening protocol for young athletes does vary from country to country and according to the resources. Most would always include a questionnaire where we talk about the symptoms that I've touched on and a family history that may be relevant. A quite inexpensive addition is to have an ECG, and most screening programs include both the questionnaire and ECG. This combination picks up most conditions, particularly if there is a doctor available to listen to the heart and make sure there are no murmurs. However, some screening programs also include an ultrasound, also known as an echo, which can then comprehensively assess everything to do with the heart. And the ideal screening, therefore, some may suggest, would be a questionnaire, an ECG, and an echo. Over the age of 35, as I've mentioned earlier, there are other conditions, particularly cholesterol buildup within the coronary arteries, that are not detected by the ECG and the ultrasound. The way to flag up whether that individual needs further assessment is to look at their cardiovascular risk factors. These include a raised cholesterol, high blood pressure, a family history of early heart disease before 60, diabetes, and being a smoker. In women, the other risk factors are a premature menopause before the age of 40, a diagnosis of polycystic ovary syndrome, or preeclampsia or hypertension in a pregnancy. If any of these risk factors are flagged up, or the individual has any symptoms, then adding in some form of stress testing over the age of 35 is often recommended. Indeed, in some countries, an exercise ECG is mandatory for some sports participation for those over the age of 35. The detection of coronary disease by an exercise test, however, is not always that accurate, and looking at their risk factors alongside symptoms is perhaps more important.